Bismillahirrahmanirrahim. Assalamu alaikum. Today we will discuss DNA viruses. We will start with Epstein-Barr virus infection. Globally, most individuals are infected with Epstein-Barr virus at an early age of 0 to 5 years, at which time clinical symptoms are unusual. Infection at an older age is associated with an acute febrile illness known as infectious mononucleosis glandular fever, which occurs worldwide in adolescents and young adults. Epstein-Barr virus is probably transmitted in saliva and by aerosol. The predominant symptoms of infectious mononucleosis are fever, headache, malaise, and sore throat. Palatal petechiae and a transient macular rash are common, the latter occurring in 90% of patients who have received ampicillin inappropriately for the sore throat. Cervical lymphadenopathy, particularly of the posterior cervical nodes and splenomegaly, are characteristics. Mild hepatitis is common, but other complications such as myocarditis, meningitis, encephalitis, mesenteric adenitis, and splenic rupture are rare. Although some young adults remain debilitated and depressed for some months after infection, the evidence for reactivation of latent virus in healthy individuals is controversial, although this is thought to occur in immunocompromised patients. Following primary infection, Epstein-Barr virus remains latent in resting memory B lymphocytes. It has been shown in vitro that nearly 100 viral genes expressed during replication, approximately only 10 are expressed in the latently infected B cells. Severe, often fatal infectious mononucleosis may result from a rare X-linked lymphoproliferative syndrome affecting young boys. Those who survive have an increased risk of hypogammaglobulinemia and or lymphoma. Epstein-Barr virus is the cause of oral hairy leukoplakia in AIDS patients. Epstein-Barr virus is the major etiological agent responsible for Burkitt lymphoma, undifferentiated nasopharyngeal carcinoma, post-transplant lymphoma, the immunoblastic lymphoma of AIDS patients, and some forms of Hodgkin lymphoma, and gastric cancer. Different levels of expression of EBV latency genes occur in these proliferative conditions caused by the virus, and various cofactors are also involved in their pathogenesis. For example, in the Burkitt lymphoma, the commonest tumor of childhood in sub-Saharan Africa, the interplay between Epstein-Barr virus infection and the presence of hyperendemic malaria appears to be relevant. Hyperendemic means that a disease is present all around the year, that is, an infectious disease. Epstein-Barr virus infection should be strongly suspected if atypical mononuclear cells, activated CD8 positive T lymphocytes, also known as glandular fever cells, are found in the peripheral blood. Epstein-Barr virus can be confirmed during the second week of infection by a positive Paul-Bunel reaction, which detects heterophile antibodies immunoglobulin M that agglutinates sheep erythrocytes. False positive can occur in other conditions such as viral hepatitis, Hodgkin lymphoma, and acute leukemia. The monospot test is a sensitive and easily performed screening test for heterophile antibodies. Specific EBV IgM antibodies indicate recent infection by the virus. Clinically, similar illnesses are produced by CMV, toxoplasmosis, and acute HIV infection, the so called seroconversion illness. But these can be distinguished serologically. The majority of cases require no specific treatment and recovery is rapid. Corticosteroid therapy is advised when there is neurological involvement. Encephalitis, meningitis, Guillain-Barré syndrome. When there is marked thrombocytopenia or hemolysis, or when the tonsillar enlargement is so marked as to cause respiratory obstruction. Human herpes virus 6 infects CD4 positive T lymphocytes, occur worldwide and exist as a latent infection in over 85% of the adult population. It is spread by contact with oral secretions. The virus causes roseola infantum, exanthum subitum, which presents as a high fever followed by generalized macular rash in infants. HHV6 is a common cause of febrile convulsions and aseptic meningitis or encephalitis occur as rare complications. Reactivation of HHV6 in the immunocompromised may lead to severe pneumonia. Supportive management only is recommended for the common infantile disease. Ganciclovir can be used in the immunocompromised patients. Human herpes virus type 8 Kaposi sarcoma associated herpes virus is strongly associated with etiology of classical and AIDS related Kaposi sarcoma. Antibody prevalence is high in those with tumors but relatively low in the general population of most industrialized countries. High rates of infection, more than 50% population, have been described in Central and Southern Africa, and this matches the geographic distribution of Kaposi sarcoma before the era of AIDS. Human herpes virus 8 can be sexually transmitted and through exposure to blood from needle sharing. It is thought that salivary transmission may be the predominant route in the Africa. HHV8 RNA transcripts have been detected in Kaposi sarcoma cells and in circulating mononuclear cells from patients with the tumor. HHV8 virus also has an etiological role in the two rare lymphoproliferative diseases, multicentric Castleman disease, a disorder of the plasma cell type, and primary effusion lymphoma, which is body cavity based lymphoma, which is characterized by pleural, pericardial, or peritoneal lymphomatous effusions in the absence of a solid tumor mass. Papova viruses comprises the papilloma, polyoma, and veicular viruses. These viruses tend to produce chronic infections, often with evidence of latency. They are capable of inducing neoplasia in some animal species and were among the first viruses to be implicated in tumorigenesis. Human papillomaviruses, of which there are at least 100 types, are responsible for the common skin and genital warts, and certain types, mainly 16 and 18, are the cause of carcinoma of cervix and some oral cancers, type 16 with oral cancers. The realization that cancer of cervix is an infectious disease has led to the development of papillomavirus vaccines, which have been shown to prevent disease associated with the high risk type 16 and 18 of papillomavirus, and have recently been licensed for use for vaccination of all girls at age 9 to 14 years. The human BK virus, a polyomavirus, is generally found in immunocompromised individuals and may be detected in the urine of 15 to 40% of renal transplant patients. Rarely, this is associated with impairment of function of the transplanted kidney, BK nephropathy. A related virus, JC, is the cause of progressive multifocal leukoencephalopathy, which presents as dementia in immunocompromised and is due to progressive cerebral destruction resulting from accumulation of virus in the brain tissue. Two further human polyomaviruses, Wu and Qi, have been recently identified. They may be associated with respiratory tract infection in young children. Human erythrovirus B19, also known as parvovirus, causes erythema infectiosum, fifth disease, a common infection in school children. The rash is typically on the face, the slab cheek appearance. The patient is well and the rash can recur over weeks or months. Asymptomatic infection occurs in 20% of children. Non-specific respiratory tract illness is another common manifestation of infection. Moderately severe self-limiting arthropathy is common if infection occurs in adulthood, especially in women. Aplastic crisis may occur in patients with chronic hemolysis, for example, sickle cell disease. Chronic infection with anemia occurs in immunocompromised subjects. There is a risk of hydrops fetalis 3% and spontaneous abortion 9% from infection with parvovirus B19 during the first and second trimesters of pregnancy. Boca virus is a recently identified erythrovirus which accounts for around 3 to 5% of respiratory tract infections in young children. Pox viruses. Smallpox variola was eradicated in 1977 following an aggressive vaccination and careful detection of new cases coordinated by WHO. Smallpox use in bioterrorism has resulted in the reintroduction of smallpox vaccine in some countries. Monkeypox is a rare zoonosis that occurs in small villages in the tropical rainforests in several countries of Western and Central Africa. Its clinical effects, including a generalized vesicular rash, are indistinguishable from smallpox, but person to person transmission is unusual. Most infections occur in children who have not been vaccinated against smallpox. Disease can be severe with mortality rates of 10 to 15% in unvaccinated individuals. Serological surveys indicate that several species of squirrels are likely to represent the animal reservoir. Illegal transport of small mammals from West Africa as pets can lead to infection in prairie dogs, and there can be some complications like keratitis or encephalitis in humans due to this virus. Cowpox produces large vesicles which are classically on the hands in those in contact with infected cows. The lesions are associated with regional lymphadenitis and fever. Cowpox virus has been found in a range of species including domestic and wild cats, and the reservoir is thought to exist in a range of rodents. Hepadnaviruses are a large family of viruses which are usually affecting the liver, and the representative virus of this family is hepatitis B virus. That is all for DNA viruses now. So now we move on to discuss RNA viruses. Picornaviruses, pico means small, is a large family of small RNA viruses which include enteroviruses and rhinoviruses which infect humans. The term enterovirus refers to the enteric means of spread of these viruses, that is via the fecal-oral route. The enteroviruses include poliovirus type 1 to 3, Coxackie A and B, ecoviruses, and enteroviruses 68 to 71. Poliomyelitis occurs when a susceptible individual is infected with poliovirus type 1, 2, or 3. These viruses have a propensity for the nervous system, especially the anterior horn cells of the spinal cord and cranial nerve motor neurons. Poliomyelitis is found worldwide, but its incidence has decreased dramatically following improvement in sanitation, hygiene, and the widespread use of polio vaccine. Spread is usually via the fecal-oral route as the virus is excreted in the feces. The incubation period is 7 to 14 days. Although polio is essentially a disease of childhood, no age is exempt. The clinical manifestations of polio vary considerably. Inapparent infection is common and occur in 95% of infected individuals. Abortive poliomyelitis occur in approximately 4 to 5% of cases and is characterized by the presence of fever, sore throat, and myalgia. The illness is self-limiting and of short duration. Non-paralytic poliomyelitis, poliovirus meningitis, has features of abortive poliomyelitis as well as signs of meningeal irritation, but recovery is complete. Paralytic polio occur in approximately 0.1% of infected children and 1.3% of adults. Several factors predispose to the development of paralysis, which include male gender, exercising early in the illness, trauma, surgery, or intramuscular injection which localize the paralysis. Recent tonsillectomy for bulbar poliomyelitis. This form of the disease is characterized initially by features simulating abortive poliomyelitis. Symptoms subside for 4 to 5 days only to recur in greater severity with signs of meningeal irritation and muscle pain, which is most prominent in the neck and lumbar region. These symptoms persist for a few days and are followed by the onset of asymmetric flaccid paralysis without sensory involvement. The paralysis is usually confined to the lower limbs in children under 5 years of age and the upper limbs in older children, whereas in adults it manifests as paraplegia or quadriplegia. Bulbar poliomyelitis is characterized by the presence of cranial nerve involvement and respiratory muscle paralysis. Soft palate, pharyngeal and laryngeal muscle palsies are common. Aspiration pneumonia, myocarditis, paralytic ileus, and urinary calculi are the late complications of poliomyelitis. The diagnosis is clinical one. Distinction from Guillain-Barré syndrome is easily made by the absence of sensory involvement and the asymmetrical nature of the paralysis in poliomyelitis. Laboratory confirmation and distinction between wild virus and vaccine strain is achieved by genome detection techniques, virus culture, neutralization and temperature marker tests. Treatment is supportive. Bed rest is essential during the early course of illness. Respiratory support with intermittent positive pressure respiration is required if the muscles of respiration are involved. Once the acute phase of the illness has subsided, physiotherapy, occupational therapy, and occasionally surgery have roles in patient rehabilitation. Immunization has dramatically decreased the prevalence of polio, and global eradication of polio is expected within the next 1 to 2 years. The virus remains endemic in only 4 countries: Nigeria, India, Pakistan, Afghanistan. However, there have been outbreaks in West Africa where cultural taboos have disrupted the polio vaccination, and also in Sudan. Recent studies using inactivated intramuscular poliovirus vaccine have revealed greater potency than the original Salk IPV. The greater reliability of IPV in hot climates and the scientific and ethical problems of continuing oral poliovirus OPV in countries free from poliomyelitis means that IPV has replaced OPV in the routine immunization schedules in many countries. These viruses are also spread by fecal-oral route. They each have a number of different types and are responsible for a broad spectrum of disease involving the skin and mucous membranes, muscles, nerve, heart, and rarely other organs such as liver and pancreas. They are frequently associated with pyrexial illnesses and are the most common cause of aseptic meningitis, that is, these viruses, Coxackie, Eco, and other Entero viruses. Herpangina is mainly caused by Coxackie A viruses and presents with a vesicular eruption on the facies, palate, and uvula. The lesions evolve into ulcers. The illness is usually associated with fever and headache but is short-lived. recovery occurring within a few days. Hand, foot and mouth disease is mainly caused by Coxackie A16 or A10. It is also the main feature of infection with enterovirus 71. Oral lesions are similar to those seen in herpes but may be more extensive in the oropharynx. Vesicles and a maculopapular eruption also appear typically on the palms of the hands and the soles of the feet, but also on other parts of the body. This infection commonly affects children. Recovery occurs within a week. Skeletal muscle involvement, particularly of the intercostal muscles, is a feature of bone home disease, a febrile illness, usually due to Coxsackie B. The pain may be of such severity and intensity as to mimic pleurisy or an acute abdomen. Infection affects both children and adults and may be complicated by meningitis or cardiac involvement resulting in myocarditis or pericarditis. Rhinoviruses are responsible for the common cold. Chimpanzees and humans are the only species to develop common cold. ICAM1 is the cellular receptor for rhinovirus, and it is only in these two species that the specific binding domain is present for this virus. Peak incidence rates occur in colder months, especially the spring and autumn. There are more than 100 immunotypes of rhinoviruses, which make the vaccine control impracticable. In contrast to enteroviruses, which replicate at 37 degrees centigrade, rhinoviruses grow best at 33 degrees centigrade, the temperature of the upper respiratory tract, which explains the localized disease characteristic of common cold. Reovirus infection occurs mainly in children, causing mild respiratory symptoms and diarrhea. They may be associated with diabetes. A few deaths have been reported following infection of heart, lungs, brain, and liver.